Good evening. Today we're going to talk about UTIs and catheter-related infections. UTIs, or urinary tract infections, are the sixth most common healthcare-acquired infection. Of these, almost 50% are caused by indwelling urinary catheters. This is referred to as CAUTI, C-A-U-T-I, or catheter-associated urinary tract infection. Because of this, urinary catheters should not be placed without determining that there is a need. Also important is the fact that the longer the catheter remains in place, the higher the risk of infection. A study by Monina Gizmondo states that the risk of UTI increases to 25% after 1 week of the indwelling catheter being in place, and almost to 100% if the catheter is left in place for 1 month. That is a huge risk of infection due to indwelling urinary catheters. There are 4 components to good catheter care. And as nurses, it's important for us to make sure that we are giving our patients the best care and the best evidence-based care to maintain the best possible patient outcomes. So those 4 components to good catheter care. The first one is avoid unnecessary use of catheters. We don't want to place a catheter in a person that doesn't need one. The second one is to insert indwelling catheters using aseptic technique. It's a sterile procedure. We should be practicing sterile procedure when we place this catheter. The third point is to maintain those catheters based on evidence-based guidelines and hospital policy. We don't want to keep that catheter in place any longer than it has to be there, and therefore increasing our patient's risk of getting an infection. Number 4 is to review the need for that catheter daily. And once we find that the need is no more, we need to make sure that there's prompt removal of that catheter. A urinary catheter should never be placed because of convenience, because we don't want to change our patient. There should always be evidence-based indications for use, and you should always attempt alternatives prior to placing an indwelling catheter. What kind of alternatives could we try first, you ask? For a man, we could try a urinal, and if that doesn't work, maybe a condom catheter. We could try a bedside commode or initiate programmed toileting or frequent rounding for either sex. Intermittent catheterization is another option that would work for either sex. You're probably wondering why that would be a better option than an indwelling catheter. And I get that, because you're probably thinking, well, isn't that more invasive? The patient has to go through that much more pain. What is the thought process behind that? Well, the thought process behind that is the fact that we are placing that catheter using sterile technique. So we should not be introducing any kind of organism into the patient's bladder. And the catheter is not staying in place, so it's not providing bacteria a port to travel up, and it's not providing bacteria or providing a place for urine to backflow into the bladder to cause infection. So those are just some examples of alternative methods that we could try before placing a Foley catheter. If all of those options fail, and then we really still need to justify placing an indwelling catheter. Some indications for use could include the need to monitor kidney function or monitor strict input and output in a critical care area, acute urinary retention, maybe post-operatively, or even chronic retention if the patient has kidney failure or decreased kidney function. Then it could be an option. We may need an indwelling catheter for a patient who has neurological problems. Maybe they're paralyzed or have a disease that doesn't allow them to control their bladder, whether that's Parkinson's or MS. Regardless, they might need it because they have neurologic problems. An indwelling urinary catheter might also be needed to instill medications. If a patient has bladder cancer, they will many times use that indwelling catheter to instill chemo into the bladder to help for treatment of the bladder cancer. Sometimes a urinary catheter is needed to bypass an obstruction in the urethra, and that could be due to cancer, that could be due to a hernia, that could be due to an enlarged prostate, and many other things. Another reason that we may need an indwelling urinary catheter is for irrigation. For instance, after prostate surgery, they use CBI, or continuous bladder irrigation, to irrigate the bladder to maintain, to stop bleeding, really, to make sure that there aren't any clots that form that block anything in the bladder. Another reason that we may need an indwelling catheter is to maintain skin integrity. If a patient has open wounds, if they have pressure ulcers, we don't want that area to be covered in urine. So sometimes they will place a Foley catheter to take care of that. And one more option, or one more need for a urinary catheter would be end-of-life care. That is typically left up to the patient, but they can decide that they would rather have a catheter in place instead of dealing with being changed and feeling violated. We really have to be careful with indwelling catheters because they can cause more damage than just that urinary tract infection that we talked about. They can cause a lot of other complications, including eroding of the bladder mucosa. They can cause bladder stones. They can cause urethral perforation. That sounds really bad. And it can be really bad if a confused patient pulls their Foley out with the balloon inflated. They can have urethral perforation. If a patient is tossing and turning in the bed, they can pull that catheter out. So trauma. They can make strictures form. They can actually cause bladder cancer. There's been studies done that have looked at the residual that's left in the bladder. What happens with an indwelling catheter that's left in place for a long time is that balloon sits at the bladder neck. And if the Foley is not secured correctly, if the bag is left full of urine and pulls on that bladder neck, it will stretch it out. So at that point, a lot of times the patient will start to have leakage around the catheter. To stop that, they tend to go to a bigger catheter size. So that means a bigger balloon size to stop the leakage. So they will do that, and the balloon gets bigger, the bladder neck gets stretched out, it can leave residual in there, and that residual eventually can lead to bladder cancer. And we can also have problems like catheter blockage and catheter migration. So I hope that you have gotten something out of this lecture today. We've talked about the reasons, the alternatives to an indwelling catheter. We've talked about the indications that we would need an indwelling catheter, and we have talked about complications from an indwelling catheter. Have a good night.